Hello friends, I'm Dr. Jeevat Ram. Today I will discuss about postpartum hemorrhage and its management. Postpartum hemorrhage remains a major cause of maternal mortality and morbidity worldwide. Approximately 500,000 women die annually from causes related to pregnancy and childbirth. What is postpartum hemorrhage? Postpartum hemorrhage refers to any amount of bleeding from or into the genital tract following the birth of the baby up to the end of puerperium. Incidence in the developing world. Several countries have maternal mortality rates in excess of 1,000 women per 1 lakh live births. And World Health Organization statistics suggest that 25% of maternal deaths are due to postpartum hemorrhage, accounting for more than 1 lakh maternal deaths per year. Types of postpartum hemorrhage. Primary postpartum hemorrhage is the hemorrhage occurring during the third stage of labor and within 24 hours of delivery. Secondary postpartum hemorrhage is hemorrhage occurring after 24 hours of delivery and within 6 weeks of delivery. It is also referred to as puerperal hemorrhage. Causes of primary postpartum hemorrhage are atonic uterus, trauma, mixed combination of both atonic and trauma, written product of conception, uterine rupture, uterine inversion, blood coagulopathy. Causes of secondary postpartum hemorrhage include written bits of cotyledon or membranes, infection, cervico-vaginal laceration, endometritis, subinvolution of the placental site, secondary hemorrhage from C-section. Other rare causes: chorion epithelioma, carcinoma cervix, placental polyp, fibroid polyp, and puerperal inversion of uterus. Risk factors for postpartum hemorrhage include prolonged third stage of labor, multiple delivery, episiotomy, fetal macrosomia, history of postpartum hemorrhage, ground multiparity, placenta previa, placental abruption, pregnancy-induced hypertension, infection. Symptoms of postpartum hemorrhage include massive blood loss, passing large clots, dizziness, lightheadedness or fatigue, decreased blood pressure, increased heart rate, swelling and pain in tissues in the vaginal and perineal area. Fortis mnemonic of postpartum hemorrhage: tone, atonic uterus 70%, trauma, laceration, hematoma, inversion, rupture 20%, tissue, written tissue, invasive placenta 10%, thrombin, coagulopathies 1%. Prevention of postpartum hemorrhage: antenatal, improvement of the health status, high-risk patients, blood grouping, intranatal, slow delivery of the baby, expert obstetric anesthetist needed, spontaneous separation and delivery of placenta during C-section. Active management of third stage of labor, examination of placenta, induced or accelerated labor by oxytocin, exploration of uterovaginal canal to observe the patient for about 2 hours after delivery. Active treatment of postpartum hemorrhage: rub up the uterus to stimulate contraction and retraction, administer ergometrin 0.2 mg intramuscularly. Symptometrin intramuscularly may be given instead of ergometrin. Expel the placenta with the next uterine contraction by fundal pressure or controlled cord traction. Empty the urinary bladder by catheterization. A second dose of symptometrin or ergometrin may be given in 10 minutes if bleeding is not controlled. Pharmacological treatment of postpartum hemorrhage: drugs of choice, injection oxytocin, IM 10 international units, or injection ergometrin, IM 0.25 to 0.5 mg, or tablet misoprostol 800 to 1000 microgram orally or rectally. Give injection oxytocin IM 5 units after delivery of the infant. When no response, gives injection oxytocin IV infusion 10 to 20 units in 1 liter of normal saline, running at 10 to 20 drops per minute. Second choice: injection ergometrin IM 0.5 mg after delivery of the infant. in the absence of myometrial contraction and to prevent postpartum hemorrhage. Use ergometrin cautiously in hypertensive heart disease patients. Management of true postpartum hemorrhage. Tone. Uterine massage. If the uterus is soft, massage is performed by placing one hand in the vagina and pushing against the body of the uterus, while the other hand compresses the fundus from above through the abdominal wall. The posterior aspect of the uterus is massaged with the abdominal hand and the anterior aspect with the vaginal hand. Uterotonic agents. Uterotonic agents include oxytocin, ergot alkaloids, and prostaglandins. Oxytocin 10 IU should be injected intramuscularly, or 20 IU in 1 liter of saline may be infused at a rate of 250 ml per hour. As much as 500 ml can be infused over 10 minutes without complications. Methyl ergonovine. Methergin and ergometrin. A typical dose of methyl ergonovine 0.2 mg administered intramuscularly may be repeated as required at intervals of 2 to 4 hours. Prostaglandins. Carboprost can be administered intramyometrially or intramuscularly in a dose of 0.25 mg. This dose can be repeated every 15 minutes for a total dose of 2 mg. Misoprostol is another prostaglandin. It can be administered sublingually, orally, vaginally, and rectally. Doses range from 200 to 1000 micrograms. The dose recommended by FIGO is 1000 microgram administered rectally. Trauma. Lacerations and hematomas resulting from birth trauma can cause significant blood loss that can be lessened by hemostasis and timely repair. Uterine rupture. Symptomatic uterine rupture requires surgical repair of the defect or hysterectomy. Uterine inversion is rare. Tissue. Classical signs of placental separation include a small gush of blood with lengthening of the umbilical cord and a slight rise of the uterus in the pelvis. Placental delivery can be achieved by use of the Brown-Andrews maneuver, which involves applying firm traction on the umbilical cord with one hand while the other applies suprapubic counter pressure. Thrombin. Coagulation disorders, a rare cause of postpartum hemorrhage, are unlikely to respond to the measures described above. Most coagulopathies are identified before delivery, allowing for advanced planning, preventing postpartum hemorrhage. Surgical management of postpartum hemorrhage. Transvaginal uterine packing. Conservative surgical approach. Uterine artery ligation, ovarian artery ligation, vaginal artery ligation, internal iliac ligation, angiographic arterial immobilization, hysterectomy. Complications of postpartum hemorrhage: blood loss, shock, death, septicemia, orthostatic hypotension, anemia, fatigue. Conclusion. Postpartum hemorrhage, defined as the loss of more than 500 ml of blood after delivery, occurs in up to 18% of births. Blood loss exceeding 1000 milliliter is considered physiologically significant and can result in hemodynamic instability. Uterine atony is responsible for most cases and can be managed with uterine massage in conjunction with oxytocin, prostaglandins, and ergot alkaloids.